I'm Mona Shahriari, and I'm Associate Clinical Professor of Dermatology at Yale University and the Associate Director of Clinical Trials at Central Clinic of Dermatology Research. So I think there's a lot going on in the AD space, but one of the biggest issues we're currently having is defining atopic dermatitis as a systemic disease. If you ask half the experts who treat the skin, they're going to say AD is a skin deep condition that doesn't necessarily warrant systemic treatment. And then you ask another half who are going to say, yes, this is a condition that impacts the body on more levels than what we can see, and the skin doesn't always tell us the whole story. And this is a problem because if you look at the psoriasis space, we've done a really nice job of defining what it means to have systemic disease in addition to just the skin manifestations of psoriasis. We've talked about psoriatic arthritis, inflammatory bowel disease, cardiovascular disease. In AD, there are reports that the AD impacts other organ systems as well, but it hasn't been done in such a nice way. There are reports of cardiovascular disease. We see in our children the atopic mark progressing because of the AD that lingers around. We have new growth data that shows that kids who have moderate to severe AD may not reach their full growth potential. There's even data in pregnancy that shows having AD can actually have negative impacts on the mom as well as the unborn fetus, and also some reports that AD can actually impact fertility. So all of these make us think that, you know what, systemic aspects of AD also need to be considered. From my standpoint, this is something that I definitely consider in day-to-day clinical practice, and that's why I have a low threshold to consider systemic therapy when I'm treating someone with AD. But I think the biggest challenge is if the world doesn't recognize AD as a systemic disease, we're going to continue to have under treatment. So I think that's really where we need to still do some work. So there are a lot of factors. I can do a 1-hour talk on the art of therapy selection, which I'll be doing a little later today. But some of the top things that come to mind, just from a pure logistical standpoint, is this someone who would prefer to have a once-a-day pill, or is this someone who would prefer to inject and forget and have an injectable medication on board? The other aspects are, do they have comorbid disease? Is this somebody who has, for example, eosinophilic esophagitis, somebody who has asthma? Can we kind of hit two birds with one stone? Do they have conjunctivitis? These kind of play into the decision to pick a therapy, but shared decision making becomes a really big part of the decision making tree. And I feel like each class has their pros and the areas where they shine, as well as things where we have to be thoughtful about. And the more we kind of use our various treatments, I think we get a better handle on that. But it's really an art, therapy selection. And so you really want to make sure that we're matching each treatment with the right patient. I kind of walk them through what are the pros and cons of that injectable option and get a better feel of what makes them wary. Because sometimes when they say, oh, I don't know if I want to go on that medicine, it might be because of just preconceived notions. Maybe they read something online. Maybe there's a myth that they are fully invested in that's just not actually true. So one of the first questions I actually ask them is, what makes you wary? And when they open up to me, I can actually walk them through that. It's interesting that you say that because I had one of my patients, a pediatric patient, that I felt was a really good candidate for dupilumab. And the parent was like, oh, I don't want to go to dupilumab. It's very scary. And I'm like, well, what about it makes you feel scary? She didn't have an answer for me. She was just like, well, pause. And she's like, you know what? I don't know. So then I walked her kind of through all the virtues of the drug. I walked her through kind of the adverse events to be aware of, and we started her child on dupilumab, and she did really well. So I think it just comes down to knowing the person in front of you, dispelling those myths, and honestly, if they're not going to be on board with what my preferred option is the first time, that's okay. We go down their treatment route, but I keep that open line of communication. So topicals, in my opinion, are a cornerstone, whether we're treating mild, moderate, or severe atopic dermatitis. And the reality is whether topicals are the only treatment for a patient, or we end up escalating to systemic therapy and keeping the topicals on board, they're part of the journey from start to finish. And I think there's this misconception that we have to ditch our topicals when we go to systemic therapy, but we can't get 100% of our patients 100% clear. That's just not feasible. So I like to keep some form of a topical on board to maintain as a touch-up paint for when some of the disease will break through. But the bottom line is, I love the topicals as an adjunct to any treatment that we currently have. The challenge we currently have is we have newer topicals on board, which have been such a game changer. They have really impressed us in terms of the efficacy they can offer in a non-steroidal form, but they also are giving a safety profile that reckons what we've had in previous generations. So we're kind of getting the best of both worlds. But because of all these benefits, they are delaying some of our patients going on to systemic therapy who should be going to systemic therapy. And that's partly because in AD, we haven't really defined what is a topical failure, what is an adequate course of a topical. So when I try to think of that, I put it into three categories. It's either an efficacy failure, which means either your skin is not clearing or the itch is not under control. It's an adverse event or tolerability failure, which we all know what that is. Something happened, they can't be on the drug. Or it's a feasibility failure. Maybe the topical is great, but it's just not feasible for the amount of body surface area they have, or just the regimen is too complicated for them based on their lifestyle and their schedule. But in that efficacy bucket, that's where we kind of get hung up. And that's where therapeutic inertia happens, because with the newer topicals, now people are cycling through more and more. So my definition, which I want somebody in some major organization to come up with this definition that we can apply across the board, is that if somebody does 2 consecutive 4 to 6 week trials of any topical and they can't get to a BSA of 1% or better, they can't get to clear, almost clear, and they can't get that itch down to a 2 or better, it's time to add a systemic to their regimen. I feel like prevention is the best thing to do. I counsel them from day one so that we can avoid the impatience coming down the road. Because I kind of feel for my AD patients. People think, well, AD patients will put up with a lot because they've had their disease for so long. I actually think the contrary. We've promised them the world as a specialty and we've failed miserably. So when a treatment is not working, they're very quick to think, this is just like all the other treatments that I've gotten. Why should I stick with it? So at the get-go, I tell them, all right, this is the realistic expectation of what you can expect. In 4 weeks, 8 weeks, 16 weeks, how long are we going to give this drug to work? But I check in with them periodically. My first touch point is always at the 4-week mark, no matter what drug I start them on. That's partly to kind of see what the insurance piece has been and make sure they can continue on their regimen, but also to keep that touch point and make sure I can reassure them and help them move in the right direction. Because one thing, especially for patients with skin of color, is when they see the AD fade, the dark marks stay. So they may think the treatment's not working when in fact, this is just a footprint of what was, so that additional counseling can help them adhere with treatment. But then after 4 weeks, I see them back 3 months later. I get them to that point where things are in good shape, and then we spread out the visits. So again, that hand holding, I think, helps the process. But I also tell them, you know what, if we're not where we need to be, I have a lot of other targeted treatments that I can give you. So we'll just take it step by step and just know this is not your only option, but it is a lot of counseling, hand holding, and remembering at the end of the day, this is hard on them. They're living with their AD every single day. So all we can do is just help them guide them through the process. So I don't always ask them about how often are you taking this medicine or how often are you injecting it. I ask them, how many injections did you forget? How many pills did you forget? And I think that kind of opens the door to a more truthful answer. You may not necessarily get the right answer that you're looking for, but part of it is that. Part of it is just looking at their skin. If there is a drug that should be working and an individual's not getting better, I start to wonder what is going on here. And I remember actually one of my patients back in the day, and this was for psoriasis, not for eczema. It was a child who was on one of the blockbuster medicines that work so fast. Every visit he would see me, nothing had changed. And I was like, this is very odd. So I asked the mom, are you sure he's taking it? And she was like, oh yeah, he's doing his own injections. I'm like, can you just go and check? They went to the basement. There was a fridge full of injectable medicine. So then we realized, okay, someone needs to be monitoring it, but you have that gut instinct. Like I think we're kind of like detectives in dermatology, where you get that spidey sense that tells you, okay, something is off. Then I start to look for other reasons why their skin is not responding, and sometimes adherence becomes the main reason.